Thank you for joining us for the FRaBSA COVID-19 webinar. We will have a question and answer period after all of the presentations. We do apologize, but the introduction and the first few minutes of the webinar are not available audio. We do have the slides from Dr. Bloom, but the discussion itself does not start until about 1 minute and 45 seconds into this webinar. Here is the agenda for today. And with that, we will proceed to the webinar. Thank you.
And of course, one of the real conundrums about this infection is a decent serological assay. And my friend Florian Kramer at Mount Sinai developed the plasmids which are being used all the way in many, many labs across the country to do serological assays. There are, as I'm sure your group the group here is very, very well aware, some serious issues with those serology tests. And recently, another assay has come out the last couple of days looking at one of the nucleoproteins. And that is in a preprint also from Jeff Cohen's lab. And I think let's hope that that one works better, because this, there's a number of gaps in the testing for this virus as well as antibodies. But it's going to be impossible for people to figure out what has really gone on until we have a reliable and a simple serological assay. So hopefully we'll have one of those in the near future. Emmy DeWitt, again working with Heinz Feldman, published a paper back in February showing the efficacy of remdesivir in a rhesus macaque model of MERS coronavirus. And they very, very recently put out a preprint showing that remdesivir also had beneficial effects in the same rhesus macaque model that they established for SARS coronavirus type 2. In that preprint, they started treating those monkeys at 12 hours after infection, and it reduced the symptoms and it reduced the virus load, although it didn't completely eliminate virus shedding. So you may want to look at that if that's something that interests you. And then, so for future directions, the things that we're going to have to focus on, and people are focusing on this at RML and at other places as well, all the way across the world really, is serosurveillance. That's going to depend on a decent, widely available kit. The specific mechanisms of transmission, natural history studies. The more we learn about this virus, the more interesting it becomes with asymptomatic carriers and so forth and so on. There are a number of interventional trials going on for a variety of different therapies, apparently including Lysol and Tide. And NIH is really interested in expanding partnerships for NIH-targeted monoclonal antibody development. And many of you are aware that convalescent plasma is also being examined as a possible therapy for this. And I think what I would like to leave you with is we at NIAID and the United States and the world as a whole are very, very fortunate to have Dr. Fauci as our primary spokesman. Dr. Collins, the NIH director, refers to him as a communicator in chief. And if you didn't see the stories, there's a place in upstate New York which is selling NIH or Tony Fauci donuts, jelly donuts, and you can also find socks and coffee pots, coffee cups, and just about everything else. And with that, I am going to end my presentation, and I'll turn it back to Lolly for the next speaker. And thanks for your attention. I look forward to trying to answer your questions later.
Thank you, Dr. Bloom. Next up, we'll be having an update on biosafety from Dr. Rebecca Anderson. She is the Assistant Biosafety Officer at the Rocky Mountain Laboratory for the National Institutes of Health, and she is joining us also from Hamilton, Montana.
Thank you. I'd like to thank the organizers for giving me the chance to speak with you today. And I'll talk to you about biosafety considerations at RML in regards to SARS-CoV-2. And I'll start with a timeline for SARS-CoV-2 research at RML. The first news reports of what is now called SARS-CoV-2 were at the end of December and beginning of January. By January 16th, our IBC had approved studies with viral isolates of SARS-CoV-2 at BSL-3. Excuse me. And our CDC import permit was obtained January 27th. And shortly after that, we received our first isolate of SARS-CoV-2 virus. Upon receipt of that virus, we generated stock virus, and animal studies were started by February 14th. We're pretty fortunate that the first lab at RML to work with SARS-CoV-2 already had BSL-3 SOPs established for work with MERS coronavirus, so new SOPs did not need to be developed. We just had to update them for SARS-CoV-2. So at present at RML, we have in vitro studies at BSL-3 and rodent studies at ABSL-3, which include mice and hamsters. The PPE that we use for our studies include, at BSL-3, include N95 or PAPR, a front cover gown or coverall, shoe covers, and double gloves. Those individuals working in our ABSL-3 are required to have a clothing change into facility scrubs. They wear a PAPR, front cover gown or coverall, shoe covers, and double gloves. At this point in time, we do have sufficient PPE to perform these studies, and we are not reusing PPE, nor are we disinfecting PPE for reuse. On February 5th, we initiated our incident command structure and started evaluating critical supplies for research, as well as PPE, and we began ordering to ensure that we could maintain a minimum of a 6-month supply, which has proved valuable to us as we know there are PPE shortages. We have a central stockroom where all of our supplies are routed through, so inventory of supplies is accurate and up to date for us, and we do continue to assess those supply levels on a daily basis through our incident command structure. So we're pretty unique from a lot of other places in that we also are completing SARS-CoV-2 studies in the BSL-4, and this is strictly because of logistical reasons. So our ABSL-3 is not ideal for animal work with non-human primates, and our ABSL-4 has all of our equipment that's essential for non-human primate studies. So it's normal for us to perform non-human primate studies at BSL-4. One of the added benefits of us performing studies with non-human primates at BSL-4 is that we're not using up some of the critical PPE that's disposable like Tyvek and N95s. So we also have labs that are analyzing human serum samples from COVID-19 positive patients, and we perform risk assessments for each request to determine how to best handle these samples. In cases where possible, we do have staff irradiate the serum prior to analyzing, and then they can work with these samples at BSL-2 with standard precautions. Now, certainly that's not possible for everybody's types of analysis, so this is where risk assessment is very important. And to do that, we've used the CDC, World Health Organization, as well as FRaBSA websites as valuable resources for these assessments. So like I said, we perform those on a case-by-case basis. So we do have additional requirements for this type of work. All of our labs that have been registered to work with SARS-CoV-2 isolates or patient samples have been required to keep inventory of those samples. So that if SARS-CoV-2 does become a select agent, that we have an accurate accounting of the samples, and they can be transferred into a select agent registered space if necessary, if they're working in non-registered space. Now we have a lot of our laboratory researchers that work in containment that like to inactivate samples and bring them out for further analysis, and we allow for that. The process that we have to go through is that the IBC requires validation testing to be submitted, reviewed, and approved prior to moving those inactivated samples to a lower containment level so they can do downstream analysis. So I think that was most of the overview that I wanted to give you guys, and I'll be happy to take any questions when we get to that session. Thank you.
Thank you, Dr. Anderson. Next up, we have Megan Brose. She's going to speak on changes in public health. Megan is a lieutenant commander with the U.S. Public Health Service and the IRF Biosafety Manager at the Rocky Mountain Laboratories. She's also joining us from Hamilton, Montana.
Hello, and thank you for having me here so I can speak to you today. Like Lolly said, I'm the Biosafety Manager for the Integrated Research Facility at RML, and I'll give you a brief overview of the public health aspects of conducting research on SARS coronavirus 2 and the impacts that it's had on our community. So just to give you a little background on our community, RML is located in Hamilton, Montana, and that's a small town of about 4,800 people in the Bitterroot Valley here in western Montana. The research lab has been here since the very early 1900s, with our current campus site starting in the 1920s. The RML campus is next to and essentially part of the downtown community, and there are residential neighborhoods to the north, east, and south of our campus. So we're very much in the middle of our community. Their reaction to our research on SARS-CoV-2 has been on the whole very positive. We have seen a lot of support for our research staff, and with children and families drawing supportive messages and notes of thanks on our sidewalk in chalk, or leaving beautifully painted rocks with thank you notes at the entrance to our lab. And we even had a kind individual start a GoFundMe page to assist researchers at the lab. Even though we're unable to accept the offer as government employees, it was still a very nice gesture. Of course, you'll hear the occasional rumor that some individuals don't want us to be working with the virus or wish they'd been consulted in the process before we started the research. I think that's common at a lot of containment laboratories and communities, but for the most part, everything has been very supportive. We are somewhat unique in that we already have a lot of infectious disease research being conducted at BSL-3 and BSL-4 here, where we work on other dangerous and exotic pathogens such as Yersinia pestis, Francisella tularensis, high-path avian influenza, Ebola, Marburg viruses, and others. So in fact, there was a lawsuit filed in 2004 when our BSL-4 lab was being designed and built, and we have a settlement agreement that resulted from that with over 20 different items related to safety for our employees and the community. And some of those things included items such as building an isolation room in our facility where we can observe and isolate an employee who's been exposed to risk group 3 or 4 pathogens, establishing a contract for patient isolation with a regional referral hospital to care for employees who have been exposed to those pathogens, transportation services from RML to those the regional referral hospital, and also distributing lists of pathogens to our local physicians and healthcare workers, among many other things. So these are all very positive and useful things to show that RML is concerned about the safety of our employees as well as the surrounding community, and all of that has been very well received in the community. So having gone through all of that with the community and other interested parties, they now understand a lot of the safety measures, engineering controls, levels of redundancy, and SOPs that we have in place to protect not only our employees, but also the community as well. So ways that we communicate with the public, we have a lot of different ways to do that. Our public affairs officer is a crucial part of this process, and he's very well connected with our community, as well as Dr. Bloom, who has been a huge public figure for us and a conduit of information to the community. Our public affairs officer also issues press releases on important research that's been done and published from our lab groups so that the community can see the benefits of the research that's being conducted here. And they've also increased the frequency of that recently because of the community is interested in the coronavirus research and the pandemic. So we have a lot of data coming out regularly that they're passing on to the community. And RML also hosts public lectures routinely from leading experts and scientists for the community to attend and learn about important topics related to infectious disease, health, and medicine, things like that. So our public affairs officer also has contacts with all of our neighbors around the lab and sends them emails and distributes flyers to their homes if we have pertinent information that could apply to them or things that could cause confusion or concern. An example is if we do drills and exercises that involve a lot of entities, we have the FBI coming or FEMA or the ambulance or police department that might be visible to them and cause concern, we let them know ahead of time so they know it's not a true incident that's occurring that they need to be concerned about. Also, if we have construction projects that could lead to disruptions, noise, vibrations, they'll let them know about that as well. We also have a community liaison group that Dr. Bloom leads that meets regularly to discuss various topics that might interest the community. And that also gives us the opportunity to report any incidents that occur that can result in exposures for BSL-3 and 4 labs. We also have community members on our IBC so that they are aware of the research that we're doing and involved in our recombinant DNA and risk group 3 and 4 research proposals and SOP review. So they're integrated into that review and approval process. And then we also conduct a lot of tours of our campus and our training facility for BSL-3 and BSL-4, and sometimes of our integrated research facility that houses our BSL-3 and 4 labs so that they're able to see a lot of the safeguards that are in place, which has been really impactful. So I would say we haven't had a lot of change in our public perception over time since we've been very lucky and we've had a lot of support and positive support from our community. We're also lucky that we have a lot of support from our local officials, our state representatives, and our Montana congressmen and women and senators, which helps spread the word about how important our work is, that our researchers are doing, and all the safety measures that we have in place. We are also the largest employer in Hamilton with over 450 employees, and the community appreciates the boost that that brings to our local economy. And as I mentioned before, the lab has been here since the early 1900s, conducting infectious disease research, and a majority of the community understands the importance of conducting these research studies, probably now more than ever when they see the severe impact from COVID-19 with having no vaccines or treatments available. So these are just some methods that we have used to communicate with our community, and I'd be happy to answer any questions that you have. Thank you.
Thank you, Megan. Our next speaker, Heather Blair, she'll be speaking on BSL-3 operations. She's the Associate Biosafety Officer at Colorado State University, and she's calling in from Fort Collins, Colorado.
Thank you for attending and for the great information so far. I am going to basically talk about the permitting process and the shipping process, and then also the lack of personal protective equipment and what we have done to try and help with that. So in the beginning, the permitting process seemed to be that whoever was going to get SARS-CoV-2 from any location, domestic or international, needed a permit. However, that's no longer the case if it's from a domestic isolate. They're no longer requiring a permit. Only the permit's only required if it's an international isolate. And so that was good for us to know, and that was kind of a changing process. We also, well, I guess groups also need to make sure that the permit that they do have, to read through it and make sure if it says that you can share it or not within your entity. And so we had some issues regarding that. And so we've contacted the permitting office and got more clarification on who can share and who can't share, and that's where we learned about the domestic versus the international isolates. The permitting office is very quick to process the permits and get them out, sometimes even overnight, and so that's been great. As far as shipping, there's been a lot of questions because the CDC and the World Health Organization have information regarding shipping of specimens, and they focus on specimens. And in their documentations and in their guidelines, when they talk about the specimens, they say patient specimens, cultures or isolates. And so it seems like those, and it says that those specimens can be shipped category B, UN 3373. But researchers and others are confusing that with lab propagation of cultures and isolates. And so you want to make sure that you are following the DOT regulations. And for the SARS-CoV-2, if you're propagating it in a lab and you're isolating it in a lab, then it needs to be shipped as category A. And if you are working with patient specimens, cultures and isolates that are from patients, then it's shipped as category B. And so I was just as confused. And so during the CDC symposium in Atlanta, Georgia, is where we brought this up, and that's where they clarified specimens versus laboratory. So I wanted to make sure that the rest of the community was aware of that. And then also here at Colorado State University, like everybody else, we've been having issues with our N95 shortages and other shortages going throughout. We basically, within about a week period of time, went from using N95s in our BSL-3s, and we would do procedures and work with risk group 3 and 4, and sometimes risk group, mostly risk group 2 and 3, wearing an N95 at sometimes, and then in higher risk procedures, we would put on a powered air purifying respirator. Well, when the PAPR shortage hit, we had to change our procedures very quickly and find where to store our powered air purifying respirators because of our facility design and where things are located and what's worked with where. We have a very large, about 50 to 55,000 square feet of BSL-3 space at CSU on 3 different campuses. And so this was a challenge. And so we stepped back and we were able to, in a short period of time, get the SOPs written and the PAPRs all deconned and moved to a different location to where we could go PAPR only in our areas. And so I can talk more about that in the Q&A if people have any questions. But another issue that we had was at our facility, most of our powered air purifying respirators or PAPRs are from 3M AirMate. And 3M AirMate, unbeknownst to us, discontinued the PAPR hoods that go with the 3M AirMates. And so we found out whatever PAPR hoods are out there right now is it. And after those PAPR hoods are gone, there's no other PAPR hoods to be placed on the AirMate PAPR units. And so not only did we have to go to PAPRs only, but then we had to have enough PAPR hoods for everybody to wear their own PAPR hoods. And then we learned that they discontinued the PAPR hoods. And so we do have some VersaFlow PAPR units, and we had others on order, and everything right now is on back order. Joni Van Sickle, our Occ Health coordinator, has been doing a tremendous job in working with the vendors and with 3M in getting us in the queue for supplies for one, when we learned about the N95 shortage, to get us some N95s, and then 2, when we had to go to PAPR hoods to talk with them to see where our orders were at and if we could be moved up in the queue and other things so that we could work on the SARS-CoV-2 type work. We do have a number of principal investigators that are working with SARS-CoV-2, and I think Christy Johnson is going to talk about our agent and project approvals and what has come through the Institution Biosafety Committee and how we've dealt with that. So I'll be happy to take any questions or comments when we're in that session. Thank you.
Thank you, Heather. Next up, as Heather mentioned, Christy Johnson, Senior IBC Coordinator, Research Integrity and Compliance Office at Colorado State University. She is also joining us from Fort Collins, Colorado.
Okay. Hello from Fort Collins, Colorado. Thank you for having me. As Heather said, I will be talking, and Molly as well said, I will be talking about the IBC approval process here at Colorado State University. But just first, a little bit of background to put everything in context. As many of you already know, Colorado State is well-versed in infectious disease, studying things like West Nile, TB, yellow fever, tularensis, and plague. We have a long history of studying infectious disease. CSU also has a regional biocontainment lab, which the lab itself is specifically funded to support national needs for biosecurity and emerging disease. And so just a quick overview of our IBC approval process. Similar to many other IBCs, our IBC reviews infectious disease, human samples, and biological toxins, in addition to the non-exempt recombinant DNA. Here at CSU, we have two different types of approval forms. We have an agent approval request form, which basically gives the PI permission to possess the agent. And then the project approval request form is the approval that the PI needs to actually work with the agent and possesses the details of the who, what, where, of the specific project details. Excuse me. And within our review process, a few types of applications can be reviewed by our biosafety officer that sits on the IBC, and currently that member is Sarah Cope. The biosafety officer can review agents of BSL-1, parfs that only involve human sample, or parfs that where the agent has already been approved. And then our full committee review process involves agents that are of BSL-2 or higher, large volumes of agents, anything involving DIRC, and then as required by the NIH guidelines, anything that involves non-exempt recombinant DNA. And so along came SARS, COVID-19, and just a brief timeline of the impact that this had on us here at CSU. At the end of January, we saw our first submission for SARS-CoV-2 work. And then this was, by the time we had our February IBC meeting, we had 3 applications for 3 different projects with SARS. Because this particular agent was new to our university, albeit the investigators are very experienced and have also worked with other types of SARS viruses. But because of the sensitivity of the agent and the emerging, at that time, epidemic, it was decided to bring the PIs in to the IBC meeting and have them discuss their projects with the IBC, just so that we could have everybody at the table at once, get all questions answered, and really, make sure that the IBC understood the full intent of the research. So after those first approvals went through, things were, kind of a little quiet, at least as far as SARS-CoV-2 applications for us. And then on March 11th, there was the designation of the global pandemic. Several things happened here in Colorado. Colorado is declared a state of emergency, and CSU announced that all classes would be going online after spring break. At the same time, we in our office at the Research Integrity and Compliance Review Office received a directive that basically all research related to COVID-19 was to advance to top priority. And basically at that point what that meant was it just moved up the list, right? It just moved to the top of the list. And at that point, we didn't really have to change anything in our procedures. Again, things were a bit quiet, but then by March 23rd, we had received several new proposals within a very short amount of time, and it became evident that we were going to need to change our policy in order to expedite these approvals. Mainly because a number of them involved surveillance testing, and it was very important. CSU is in a position to assist with the local surveillance testing, and so it was vital to get these approvals out as quickly as possible. So at that time, we came up with this provisional policy. And provisional meaning that the policy itself is somewhat temporary, kind of an emergency policy, now allowing the biosafety officers to review and approve the SARS-CoV-2 ARFs, which would have normally had to go to the full IBC before. Now the biosafety officers can review those, and then at the next IBC meeting, then the IBC will review that, and if they have any additional comments or concerns, they will be addressed at that time. In addition, the provisional policy also stated that if any of these PARFs come through with non-exempt recombinant DNA related to COVID-19 research, that we may need to hold an emergency IBC meeting. And finally, we just added that this would be reevaluated every 6 months. And so what that has looked like, just kind of a quick rundown. To date, either the full IBC or our biosafety officers have reviewed 15 agent approvals and 22 project approvals for research related to SARS-CoV-2 or COVID-19 research. With the new provisional policy put into place, those average approval times have, for biosafety officer review, are 4 to 5 days, or for the full committee, because we did have to have an emergency IBC meeting. So our full review for that was down 8 days compared to our previous approval times prior to that, which were both, just a little over 3 weeks. 3 weeks. These are business days, so just a little over 3 weeks. Anyways, that was all I had to share with you. Just, how the processes that we had to change in order to help facilitate this research, and it's definitely made an impact. And I'd be happy to answer any questions during the Q&A. Thank you.
Thank you, Christy. Next up, we have Mike Burt, who is the owner of Air Filter Solutions, and he is joining us from Denver, Colorado.
Good afternoon, everybody. I'm Mike Burt with Air Filter Solutions. Can you hear me?
Yes, we can hear you.
Good, thank you. So we are a large HVAC air filtration, HEPA, and molecular filtration distributorship. in Denver, and we take care of the Rocky Mountain region. So we approach the marketplace in the supply of air filtration, and we also do retrofit new construction and design projects with engineering firms for new buildings. So our primary line of product is CamFil, and so since the start of the pandemic, our support of air filtration as the experts in the field focused with mostly businesses and organizations deemed essential. In other words, hospitals, federal, state, and local governments. So with the spread of the pandemic, the overwhelming demand for HEPA filters caused existing inventories to vanish overnight. Production disruptions stemming from raw materials shortages and labor absenteeism on the manufacturing side have extended long lead times for HEPA filtrations products. Despite the supply shortage, the immediate need for HEPA filtration remains. So customers have been forced to improvise for solutions. Our company has assisted quite a bit with several healthcare hospitals, the healthcare industry, in the design and implementation of temporary airborne infection isolation rooms. Most hospitals have insufficient facilities to provide airborne infection isolation for a surge in infected patients. Using principles based on the current standard for hospital isolation, using non-standard HEPA filtration equipment that still is readily available. So far, multiple hospitals in Colorado and in Wyoming have successfully augmented the isolation room's footprint. And so our company is very proud in helping to facilitate in some of these projects, which were all last minute and hot rush, as you can imagine. Recently, our support efforts now have expanded to include businesses and organizations previously considered non-essential. So large office buildings, schools, universities, etc. As communications start opening up and the social distancing curtails, facility managers are increasingly interested in improving their IAQ. So the immediate challenge we have as a company in enlightening our customers on what's possible and what's unrealistic regarding their air filters and the prevention of COVID-19. An air filter is a single component within a larger and more complex HVAC system designed to accomplish the proper ventilation of a building. Increasing particle size capture efficiency is not necessarily a singular solution to lower the risk of the infection. Each individual person or those responsible for the safety of the building occupants must decide the appropriate level of risk and air filtration solutions suitable for their situations. All of this is easier said than done, especially during times of uncertainty, misinformation, and panic. So like Heather had mentioned about pepper sprays, there's a high demand for air filtration right now. And because of the shortage, as I had mentioned earlier, everybody's improvising to try to help design and get products. Now that as some of the bans start to lift and buildings start to open up, everybody's addressing air filtration, HVAC air filtration, much less the HEPA filtration, as I mentioned. So that's it. If there's any questions or answers, if there's any questions that you need answered, just let me know and I'll stick around for that. Thanks very much.
Thank you, Mike. Our last speaker this afternoon is Kyle Mueller. He is calling in from Mist, Oregon. He works for Technical Safety Services and is the Associate Training and Technical Manager there. Off to you, Kyle.
Thank you, Lolly, and really appreciate the chance to kind of talk to everybody about what this has done for, on my camera too, what this has done to the certification industry. It's unfortunate to hear some of the other trials that people are going through right now, but it's good to hear that the world is still spinning in other places. So as a whole, for our field technicians, most of our procedures are relatively unaffected. I mean, we've always been in the business of contamination control. We've been going to places that have worse things than this coronavirus. Historically, pharmacies have hazardous drugs. Manufacturing sites we visit have lethal concentrations of chemicals. As many of you have already given examples of, there's research labs of microorganisms that we don't want even more than the coronavirus. And hospital labs are one of the most unknown unknowns for us ever, because that's where the people that are sick are going to go, and they're not going to know what is ailing them until that sample gets into the lab. So while we have had some techs needing reminders as to what our main goal is, most really understand what our mission and purpose is. Most of the clients that we were servicing were already essential for society, so we still have a lot of that going on, and we won't be going away, so we can still support everything that's needed. Drugs are always going to need to be made. Cures are going to need to be found for more than just this current coronavirus issue. And risks to society will always need to be mitigated and contained. So we're still going strong there. There has been some reduction in non-essential sector work. Things like greenhouses are not necessarily having us come out, which has decreased some of our response time, but some of those areas that are starting to reduce seeing us causes some concern for later. While we all have pictures of hospitals that are jam-packed, filled with emergency response patients, there are hospitals out there that don't have a lot of coronavirus patients and then therefore aren't getting any patients at all. There's no elective surgeries going on. People are avoiding going to the hospital if they can at any way. There are hospitals in many different areas that are starting to actually lay off nurses. So that's been concerning not only for us, but for them. So also a lot of increase in coronavirus specific arena. We've been doing a lot of decontaminations for biosafety cabinets. As universities aren't using a biosafety cabinet, they'll loan it to another lab so that they can be doing coronavirus testing. We're working on setting up the labs for testing, as well as areas where they're creating the supplies for the testing procedures. And then we've been kind of working feverishly on options to aid with the PPE shortage nationwide. As of April 1st, we submitted a approval for an EUA through the FDA, and the word is that today we're actually supposed to be going through some phone calls for hopefully being able to get that approved to do VHP cons, things like N95 masks in large volumes. Some logistical challenges are coming up here and there. PPE shortages are everywhere. We're affected just like anybody else. We do still have a lot of the PPE that we need, but as more and more clients start requesting that we use our PPE instead of theirs, or we try to use less PPE, there's some potential issues with that, and eventually our stores will run out as well. Travel, sticking to driving instead of flying just takes a little bit longer, but we are still able to get pretty much everywhere we need to go, and all of our technicians have their essential personnel paperwork, so that seems to be working out for us. Getting into some areas has been difficult because a lot of people aren't there anymore. Everybody's working from home. On a positive note, contamination control awareness is increasing. People are, asking a lot more questions. They're taking a lot of the testing that we do a little bit more seriously. We're getting chances to clarify proper techniques for contamination control and proper PPE for use. People want this information. That's been kind of a great thing to be able to help out the communities around us. We've been able to clear up somewhat some of the misunderstandings and misinformation. I guess one of the biggest ones that we've been seeing is the size of the coronavirus being 0.06 to 0.125 micron, and HEPA filters are only efficient to 0.3 micron. You should all know that's a farce. HEPA filters are efficient well below 0.3 micron. It's just that 0.3 micron is the most penetrating particle size. Other issues we've been running into is some of those older hoods out there that we've been trying to get replaced for years have been dying mid transfer of research on this virus. So that's been a little concerning for a few of our clients. So looking at the future, we don't know what's going to happen any more than anybody else, but we do have some concern of a surge in certifications after quarantine is lifted. All these non-essential groups that aren't having us do the certifications because nobody's there, when they come back in the same week and they want all their certifications done, that's 6 months worth of work. It's going to be a challenge, and we're trying to get prepared for that. But we're also trying to make sure that if there is anything we can safely do when we're on site for emergencies already, that we take care of that to ease the burden that will create later. We're not sure how much work is going to be left over from other smaller groups that don't weather this storm, so we're trying to prepare for that. And we've also got decontamination and decommissioning of all these temporary COVID labs once they're done working. So really the bottom line for us, and I think kind of everybody on the call, is this coronavirus is a terrible thing and it's been awful, but it has kind of acted like a catalyst to bring a lot of focus and attention onto the services that everybody on this call provides, whether it's the filtration vendors or whether it's the biosafety officers. People are starting to understand that what we do actually has purpose, and we're trying to avoid outbreaks like this in the future. So hopefully it's a learning experience as well as with everybody else. I look forward to any questions. Thank you very much.
I'd like to say thank you to all of our speakers for preparing words to relay to us today. We've now come to the point in our presentation that we're going to do a question and answer session, and I'm going to turn that over to Holly Gates-Meyer, who will be leading us through the Q&A.
Okay, so we do have a few questions. And I'm going to start out with our general question, so please feel free to just chime in. Do you think it's necessary or helpful to wipe down groceries and take packages out of boxes and those types of general precautions? Can you hear me?
You broke up a little bit, but I think maybe we heard most of that.
Okay, so if you'd like, I could repeat that. Just a general question, do you think it's necessary to wipe down groceries and take packages out of boxes and those types of precautions?
Does anybody want to answer that? I can answer personally.
Yeah, this is Marshall. I mean that's a question I think which is so hard to answer. The CDC and various state health departments and county health departments have, put out guidance on that. And I think it'd be really inappropriate for any one of us to really provide an answer to something for which, there's local guidelines for, but frankly, for which there really isn't a very solid answer.
All right, on to our next question. And really, I'm thinking maybe Dr. Bloom and Heather, you might want to answer this. They have a team at UCCS looking for partners involved in actual testing for joint work on pool testing. Their labs are only at BSL-2, and they're seeking a partner with 2+ or BSL-3 capabilities and actual experience. Any pointers on where to look for collaborators?
Well, I can tell you that the investigators here at Rocky Mountain Labs, and I suspect the same thing would be true for the folks at CSU, are getting so many requests from so many different people to test this or that or this compound or this chemical or something like this. That's a real challenge. I mean, our investigators here basically quit answering emails like that entirely because in spite of the fact that we have a number of it, as do you, I suspect, and any of the other universities involved in the research, have people that are heavily engaged in that work. you know, when you really add it all up, it's not that many people, and availability of the BSL-3 space to do those studies in is simply not adequate to test everything that everybody would like to test, everything that everybody would like to test. I think that's you know, it's an issue that I think everyone is faced with. The one saving grace, which I'm sure all of my biosafety colleagues would say amen to, is that the Division of Select Agents and Toxins has so far not classified this virus as a select agent. So that makes it easier. But anyway, that's my thought.
I'd like to also give some comments on that. Here at Colorado State University, we really filled up most of our space with our own researchers and their research projects. We do have a few collaborations, very few collaborations with outside of CSU personnel, but the space became limited really, really quickly and occupied really quickly. And we've got labs all the way from doing animal testing to vaccine possibilities to antivirals to running the swab tests here. And so it just very much like, a little bit like Christy and Heather were talking about, in a few days and in a couple weeks, seemed like we were pretty well fully committed and out of space to conduct the research, any more research efficiently and safely.
Okay, so the next question is very good to have all researchers inventory the COVID-19 patient samples. But the question is, how realistic is this if it becomes a select agent? How to account for, given its prevalence in the population?
Well, I realize that it's very prevalent out there, but certainly as they receive these shipments, they can have an accounting of those samples when they receive them and until the point that they inactivate them. So that's what we're expecting of our researchers. As they expand stock virus, they have to have an inventory accounting of that stock as well.
And then this goes back to the question about shipping again. And they say, I'm sorry, I might have missed it, that SARS-CoV-2 cultures to be shipped as Category A. Heather, I think you talked about.
Can you say that question again, Holly? I can't hear you very well.
Oh, sure. So they said that they may have missed what you said specifically with shipping the SARS-CoV-2 cultures, but who was the entity that specified that they had to be shipped as Category A?
The CDC. Bill Arndt at the CDC symposium, he clarified and stated that for lab cultures, propagating cultures and isolates, they need to be shipped as Category A. For patient specimen isolates, cultures, and specimens, those can be shipped as Category B.
Okay. And here's another question. It's actually something that you spoke to, Heather. Breathe Easy or AirMate fluids, which one do they cure? We were referring to the package.
The 3M AirMates, those hoods have been, they've basically been discontinued. For the Breathe Easies, you can purchase a breathing tube that is able to connect to the new S series, but they don't have one for the 3M AirMate.
So maybe Mike, this is a question for you. Do you think that persons working in older buildings with older HVAC systems would be at risk when we return to work?
Could you repeat that one more time?
Sure. do you think that persons who are working in older buildings with older HVAC systems would be at risk when they return to work?
When they return for what?
To come back to work to populate the building that has an older HVAC system.
And so, and say one more time, what about that?
Do you think that persons who are working in older buildings that have kind of an antiquated HVAC system, do you think that they are going to be at risk when they go back to work in those spaces?
So that's been a popular call in the last 5, 6, 7 business days, because now we're progressing to a situation where properties are going to start opening up, and so there's genuine concerns for the facility techs. What do they need to do? How? And so, you know, probably a real good idea. As a matter of fact, it was published in an ASHRAE Journal magazine, I think the March 24th Journal magazine, which talked about what is the best way to approach filtration changeouts, how to dress, and how to how to change the filters, how to handle them gently, so on and so forth. So if it's about the air filtration changeout, there's been some articles mentioned that maybe that the virus may die after 72 hours of landing in the filter itself. Maybe because of a baked mold or something of that nature, where the virus will die. But regardless, we think that the technicians should probably dress up and follow procedures that way: gloves, masks, face protection, and then bag the filters and dispose of them properly, and then get rid of the clothing in a proper procedure, and then wipe down and wash off. To say somebody's going to capture something, that's not it's not for me really to say, and I don't know that anybody's going to take the risk of suggesting that that they will. They vulnerable, maybe so.
Okay. Thank you for that. Regarding transmission, do we know if urine from an infectious person can contain infectious SARS-CoV-2? Who would like to take that one?
Hi, Holly. This is Heather. We can't hear you very well. Is there a way that you can come closer to the mic or change something? Sorry.
Yeah. Can you hear me better now?
Yes, much better. Thank you.
All right. So, do you think, regarding transmission, do we know if urine from an infectious person can contain infectious SARS-CoV-2?
This is Marshall. As far as I'm aware, no one has demonstrated that. I mean, the virus has been demonstrated to be shed in a variety of secretions from one end to the other of the body. But as far as I know, it hasn't been identified in urine so far.
Thank you for that. And another question for you, Dr. Bloom. Could you perchance speculate on why no bat or other viruses isolated thus far show evolutionary intermediates with some portion of the unique 4AA extra polybasic domain that the SARS-CoV spike has?
The short answer to that is no, I can't comment on that.
Okay. This is a question I think that is on all of our minds, because we're struggling with this now. What measures are you taking to phase research back in? That's fair game for everybody.
Well, I can say here at Rocky Mountain Labs, we're part of the National Institute of Allergy and Infectious Diseases, but we're fortunate because we're about almost 3,000 miles distant from the main campus. And we, as Becky noted, we set up our incident management team early in February to start off doing logistical planning, and then when the scope of the pandemic became apparent, we started putting together plans to step down and vacate the lab, even before Dr. Collins announced it on March 20th. And over the last couple of weeks, we've been putting together reconstitution plans, both for the laboratory themselves, which will be certainly critical, but as you, as biosafety professionals, will understand, there are a lot of moving parts to stopping something, and there are a lot of moving parts to getting something started again. And so our reconstitution plan, it's not finished, but it's getting close, is going to address all of those things, and we're probably going to do some sort of a phased reconstitution of research and support services. I mean, I think in many ways, the listeners or the viewers to this can really think about that question in sort of the same way you might ask, well, okay, we just got a brand new building. How are we going to move into it? Who's going to move into it first? What support functions do we need to have operational before, scientists can even start entering? The other thing, I think, which has become apparent to us, and I'm sure to all the other institutions too, is that our IT and computer specialists are really the virtual glue that's holding the operations together, with everybody sitting in their living room or dens. And when everybody comes back to work all at once, there's going to be a huge demand on the IT staff, because we've all been working from home on a laptop, and who knows if our desktop computers are even going to start up again. So anyway, I mean, those are complicated questions that a lot of places are trying to cope with.
Next question. Considering social distancing guidelines and shortage on supplies and space, what or when are you going to institute your plans to bring back non-COVID research at your institution?
Well, the same thing we're basically, that's going to be considered much of in the NIH step-down process, work on the coronavirus was allowed to go on, although any projects that were going to be done on coronavirus had to go through an approval through our institute as well as by a central NIH committee. And there are requirements imposed by the NIH in terms of like social distancing, limiting the number of people that can be in a given laboratory space. I mean, certainly once you're in a BSL-3 or a BSL-4 containment environment, I think the point of social distancing is a little bit comical. But, for BSL-2 and laboratory spaces and administrative spaces, the rules are you're not supposed to have more than one person in sort of a cubicle, which would normally house about 4 to 6 postdocs or technicians or students. If it's a BSL-2 lab, you're not supposed to have people working closer than 6 feet. And so the way our investigators here are coping with that is by staggering people. So like a lab like Dr. Munster's, which has, I don't know, let's say 10 or so people, some of them come in at this time, some of them come in at this time, and some of them come in at this time. And there are, of course, recommendations that people wear cloth face coverings or some sort of face covering when they're working, but I don't think that's being widely followed. So that work has been going on. So our reconstitution plan, so as part of our reconstitution plan, there'll be an acknowledgement that that work is already going on. The new work that starts will probably also be subject to the same social distancing requirements. And I know as our various states start to open up, there are a lot of us that are really worried that there's going to be a big spike in new cases from everybody going down to the bar or the soccer game. So I think everyone is, treading very lightly and very cautiously, and it's not going to be a one-size-fits-all kind of solution.
Okay, thank you. What is the recommended biosafety level for working with formalin-fixed tissues? Can a risk assessment adjust this recommendation?
So I think if you have validated the formalin activation of those samples, they certainly can be worked with safely at BSL-2, but you have to make sure you do the experiments to ensure that your activation is effective.
Thank you. So this is a question, I have something similar, and it is, can you expound on therapies being studied using Lysol and Tide? So there's actually another question to that effect as well. And I think this stems from a White House briefing the other day.
Well, I would never want to try to second guess what the president says, but I think there was a lot of surprise expressed when he suggested that people might want to start injecting or ingesting disinfectants like Lysol and bleach and an ultraviolet lamp. I think whether those are effective or not as topical disinfectants for tabletops or steering wheels or computer keyboards or something like that is one thing. And the CDC and others have put out, fairly long lists of approved disinfectants. So, but I certainly don't think anything like that is appropriate for internal consumption.
Can you discuss, and this may be for Mike and also for Kyle, can you discuss the importance of inline testing of HEPA filters and decontamination methods of HVAC systems prior to changing filters?
Decontaminating before changing out inline HEPA filters, especially if they're an exhaust filter, is kind of an option depending on what kind of inline system you have. There are a lot of bag-in, bag-out systems that are very functional and with proper PPE can eliminate or reduce to an acceptable level the risk of exposure from anything that could be on that exhaust filter. However, performing a decon before doing it just increases the probability that there won't be any contamination issues. And then, of course, the integrity testing of that inline filter. If you need a HEPA filter, then it's got to be proven to not be leaking. Otherwise, you don't need that sort of filter in place. So that would be my answer.
Regarding, go ahead, sorry.
So I would just say that we would typically lean towards companies like TSS for those HEPA filter applications where it does call for certification. Now there may be some that don't. As an example, maybe some hospitals, when they're doing their air handling equipment, they don't certify or clean their HEPA filters, not clean their HEPA filters, but when they're changing out their HEPA filters, they don't have any set criteria that they need to go by. But otherwise, TSS or companies like TSS for certification, there's a criteria that's laid out, and they're the people that would do something like that for both install certification and then whatever the certification is for change out, like Kyle had mentioned, bag in, bag out systems.
Okay, thank you. Regarding air treatment or HEPA filtration, are you seeing UV being used as an adjunct method of treatment in ventilation systems or rooms? And along those lines, also decontamination utilizing hydrogen peroxide vapor being used outside of healthcare facilities.
Holly, there was some feedback, some squawking going on.
Okay.
And Kyle, we couldn't hear you because you were muted.
That would help, right? We have been fielding some questions on vapor or on the application of UV light in the HVAC systems, and there are so many different systems out there and so many different potential applications. It's hard to speak on it in totality. I personally am not a fan of trying to use UV light in HVAC systems, only because of the amount of exposure required to neutralize a lot of the items or contagions that we'd be concerned about, and the potential side effects of all the ozone created if it's an ozone light. The testing that is required as per OSHA, if you're using a UV light for a germicidal reason, it is supposed to be tested every year so you can confirm the output is appropriate and confirm the contact time. Again, when using these things in especially fast-moving air, the amount of microwatts per square centimeter that you need to be putting out is very, very high. And while it may look like that light is still working, if it's not tested, it can just be a black light not putting out the essential UVC necessary. And then the question on VHP decontaminations outside of healthcare industry. Yes, there's a lot of different applications in which we're utilizing vaporized hydrogen peroxide on a normal basis. I don't know if there was something a little bit more specific to this situation that the question was based on.
That pretty well covered it, according to this question. Okay. Next question is, I'm curious as to what the processes are specifically to assure that samples containing SARS-CoV-2 are deactivated for work before being moved, I presume, from the lab. The question was cut off.
So we require people do validation testing of their inactivation procedures. So it's just that if they're inactivating with, say, a chemical fixative or something similar, that they have to treat the samples, whether it's infected cells or tissues. They treat it with exactly how they want to treat it. They usually do some means of washing out those fixatives, whether it's washes with PBS or they perform dialysis. They typically then homogenize and then put that back on cells. And what we're looking for is that they can make sure that there is not viable virus maintained in that inactivated sample. So our expectation is that they do 3 independent experiments, at least performed in triplicate, and then that data is presented to the IBC so that we can review it. We like to make sure that it's properly controlled, so there's appropriate positive and negative controls, that an assay was done, was scientifically valid, and then once we've gone through that process, we give them the approval to inactivate and remove samples from those containment labs.
So at CSU, we do something very similar. We don't have 3 independent experiments, but we have them do the experiment in triplicate if it's, it could be done together or separately. And then again, positive and negative controls. Basically, the procedure is the same as Becky mentioned. The only difference for us is that the biosafety officers approve the inactivation and validation of the inactivation instead of it going to the IBC.
Thank you. So we may have time for one more question, and then I think we're going to have to wrap this up. Can you speak to the TSS method for HEPA filter change methods, the PPE utilized, and decon protocols? Hey, Kyle, this is for you.
Yeah, I'm not 100% sure what kind of item for HEPA filter change we're talking about, because that does vary if we're changing HEPA filters in a biosafety cabinet versus a bag-in, bag-out inline system. And it also depends on the contamination source. If we're working in a biological safety cabinet, often we'll do decontamination of formaldehyde gas or with chlorine dioxide gas or vaporized hydrogen peroxide prior to removing anything from the inside, and that's normally sufficient to neutralize anything inside. But if there's chemical contaminants as well, biological decontamination won't do anything, and then we have to implement full body covering, Tyvek with hood, full face respirator, double gloves, as well as tenting, secondary containment in the room, floor covering. Normally our bag-in, bag-out procedures for exhaust filters is very similar to where we will use full covering, full face respirator, the Tyvek double gloves, and then depending on where that unit is located, there may be secondary tenting around it. If we can decon it, sometimes that makes it easier, less, depends on the contamination and the location.
Okay, great. I think we are out of time. We still had a few questions left, but we will address those questions and send out emails and hopefully cover the questions that didn't get addressed during this session. Thank you.
Okay, I think we can wrap this up that with saying that it's been a really, really good hour and a half. Excellent presentations by all the panel, and the audience participated with a lot of questions. Wish we had a little more time that we could answer those, but like Holly said, we'll try to get those answered one way or another back to you. I want to remind people also that the Front Range Biological Safety Association is going to hold a symposium, our second overall biosafety symposium at the University of Colorado Boulder this fall, October 1st, and we will be putting out more announcements on that as we go forward. Also, I want to thank the panel, the speakers for the job that they did today and for taking time out of their busy schedules to do that. Thank you to the audience for your participation and for the questions that you submitted. I want to especially thank the FRaBSA Council and the Education Committee. Lolly Gardner is the chair of the Education Committee and took a lot of the lead on this. And we never would have been able to put this on as a webinar if Cindy Norton, our communications director, had not stepped up and changed the delivery systems as the number of people grew, and it's worked out really, really well. So thank you all, and with that, we will sign off.
Goodbye. Happy Friday, everybody.